Hey everybody, my name is Lon Stroschein, former public company executive turned best-selling author, coach to elite performers, and self-declared lifestyle engineer. In 2022, I made a decision that changed everything for me. I left my job as a public company executive, and I left without a backup plan, without a resume, and without a Rolodex of clients. I left with a belief that the best days of my life were right in front of me, and that they weren't going to be lived where I was standing. Since that day, my mission has become to be a champion for the best decade of your life. This podcast is here to give you the tools, the stories, and the perspective you're going to need to finally make a bet on you. We're going to talk about the hard stuff here. The conversations here will be raw and real. There are no post-edits, no do-overs, and no limits. You'll hear stories from people just like you who've made the trade, and from those who are right there in the trenches, right where you are, still trying to figure out. If you're here, you're ready to be up to something. And if you're here, you're one decision away from a radically different life. Welcome to the Normal 40. I'm going to see all of you on the podcast. Josh Russell, dude, it is super cool to have you here. And now look, I want the listener to know something. Josh and I don't know one another. We don't know one another from our past. We don't share a history. We just came upon one another through mutual friends on what I would call the Normal 40 Highway, but just through our professional networks. And we got on the phone for a few minutes and we got into a couple of really fascinating topics, fascinating to me and fascinating to the people who are on the Normal 40, because we very quickly got into this place of intent and living on mission and doing things at this point of life where they're hard and they're not obvious, and how you wrestle through them and how you get there. And so we just had a conversation like I have with so many people. We were just rambling. And that's when Josh started to tell me a little bit more about what he does. And it dawned on me that in my book, The Trade, I talk about the 5 Ds that will shock you into a new way of thinking. Death. If there's a death in your family or death near you, it will shock you into a new way of thinking about your reality in this moment. A diagnosis that you get or a diagnosis that somebody near you that you love gets. It shocks you into a new way of thinking. Drinking. It can be a Tuesday night and you have your 3rd or 4th glass of scotch and you do that again and again and again. Your wife is in the bedroom, your kids are in bed, and you can drink yourself into this oblivion of, well, it can lead to a death or a diagnosis, but usually before that, there's an intervention and something that will absolutely shock you into a new way of thinking. You can get downsized. Your company can come to you and say, thanks, but no thanks. And when the number of heads in your house go down instead of up, your kids start graduating, those 2 types of downsizing just change how you see the next decade of your life. The last one I write about is divorce. How many people have you talked to are going through a divorce? They act surprised that it got sprung on them, but in retrospect, looking back, you know, probably full well why it happened. And then the last one I write about is you can decide. You actually don't have to wait for one of these Ds. You can decide that this is your time to do something different. And it's not a time to blow things up. It's time to just start. And so we were talking about all these things. And then it dawned on me that Josh is an ER physician, an ER doc, first and foremost. But then he ventured into this new place. Well, I don't want to get too far ahead of myself because I don't really know the story, but I know that somewhere in your story, you moved to palliative care, which means you're helping people in their final days. So you went from this emergency room physician where you're trying to help people survive. You're trying to revive them, help them get to the next day, recover from this disaster that's just happened, to this place of helping people transition. I don't know if that's even the right word, but transition to end of life through a process, through care, through love. And that got me thinking about all the Ds. And so I just said, let's do a podcast. So that's what brings us here. So Josh, dude, I am so excited to have you here. Thanks for joining the Normal 40 podcast.
Well, thank you for having me. I am thrilled to talk about this topic of death, which sounds sort of morbid, but I think it's actually something that is overlooked by most of our society. And I'm happy to share the story of how I got into palliative care. It's not the only thing that I do, and I think it's worth probably talking about why, because I did do it exclusively for a while, and that was also not a good fit.
I love it, man.
Talking about
So
with that.
let's do this. I kind of made some assumptions about your journey right off the bat that I shouldn't have done. So let's go back. Here's what I want to know. Tell me, where were you in the third grade and what was going on in your world?
Well, that's an interesting question. I actually was at a school called Pineview School, and it was a 2 through 12 magnet school in Sarasota, Florida, not far from where you sit, as I
Yeah,
understand
no
it.
kidding, man. I'm gonna go check it out, see if your name is on the big board somewhere.
Maybe, I spent a lot of time in the principal's office, so maybe it's, on the do not admit list or something like that. But I spent my childhood in Florida, and I'm an only child. And around the time of third grade, it wasn't exactly third grade, I already knew I wanted to be a doctor. That's one of the things that is something that predates my coming online, as I say it, is I don't remember how I came to that conclusion that I want to be a doctor. My dad was an eye doctor, an optometrist, and so I think I had some inkling that that was of interest to me from probably wanting to follow in his footsteps in some respect. But it's one of those professions that I sort of wish that was not like automatically praised as it was, because as a child I said I wanted to be a doctor, and people would say, "That's great." They wouldn't say why. They wouldn't say, "Tell me about your interest in being a doctor. Like, let's explore that." In the way that they might say if you wanted to be a stand-up comedian or an artist, it's just automatically a good thing to become a doctor. And for some people it is, and for others it may not be. I have enjoyed my long and winding trajectory as a doctor, but I certainly am very far from where I started when I finished residency.
I talk to a lot of doctors and I find it fascinating. They all have this moment. You said you didn't remember the exact moment, but you articulated that by third grade, you had already come to the belief that in your lifetime, you are going to be a physician. You didn't know if it was emergency medicine. You didn't know if it was palliative care. You didn't know if it was orthopedic, doesn't matter. You felt compelled to move into medicine. And there's the people I talk to, physicians, attorneys, accountants, and C suite people, they all decide very young what they're going to do with their life. They all know. They all know if they're going to chase to be a CEO. They all know that they want to be a doctor. They all know they want to get into law school. I mean, the people who follow into those, they're a very specific avatar. There's no wandering. Well, after when I was 37, I thought I'd go to med school. Yeah, you're going to find those stories on occasion, but by and large, the people who are here, the people who are listening, are people who knew when they were very young that this is what they were going to do. So I love that as a starting point for you. So take us through, your dad was a physician. Take us through, I don't know how long you lived in Florida, but move us through high school and moving into med school.
I mean, I had a pretty, I would say, average, uneventful trajectory through those years. I mean, the standard adolescent struggles. But early in my high school time, my father was diagnosed with Parkinson's disease, and I was pretty young. He was almost 40 when I was born, and I think he was diagnosed around 51 or something like that, 52. So maybe I was actually in middle school. And that was definitely a blow to the family. He retired probably sooner than he needed to, but he was very afraid of losing his ability to practice. And it ultimately was the cause of his death, although it took about 30 years, 25, 26 years. But it was a long, slow decline. And this dovetails into the reason, or at least partially, why I decided to go back to training after probably 7 years or 8 years as an emergency physician exclusively, and do a fellowship in hospice and palliative care. And that is because my dad was getting care at the University of Michigan Medical Center. It's one of the top hospitals in the country, and was seeing some of the best neurologists, was on the most cutting edge treatments. He was in several clinical trials. Throughout this process, there was virtually no discussion about his wishes for his end of life care and the reality that he has an incurable degenerative disease that will be more than likely at least partially responsible for his death. And it was emblematic of how our medical system facilitates and enables the denial of death. And I think the denial of death is the title of a book that is I want to discuss more, but the denial of death is the default state of human beings. And the reason we deny death or refuse to face the reality of it is complicated, but it is true for people. And so they're coming to doctors, medical centers, looking for hope, looking for something that is going to give them some little piece of data or a treatment, a new discovery of a pharmaceutical that is going to be like, oh, I'm not actually going to die because there's this thing. And we as physicians, nurses, anyone in the healthcare professions don't want to be the ones who wrestle hope away from anyone, for sure. And because of that, well-intended sentiment, we also allow these discussions of death to be tabled for a distressingly long period of time until people are often not even able to communicate what their wishes are for the last days, weeks, and months of their life. So that was, I think, a big part of it. And then simultaneously, there were the experiences I was having in the emergency department.
Yeah. So I want to go back to your dad contracting Parkinson's. This is before you go to medical school. This is before you even have a chance to apply for medical school. So just tell me about your process of becoming an ER doctor.
So I chose to become an ER doctor mostly because I was pretty indecisive about which specialties seemed the most interesting. And the beautiful thing about emergency medicine is no 2 days are alike. And for somebody that gets easily bored, even I would say, by routine, I knew that I would do poorly if I was seeing, one diagnosis over and over again, which some doctors do, and that's great if you have that diagnosis. I preferred the pace of emergency medicine. I preferred the variety of emergency medicine.
Where were you in the process when you decided a pivot? Now, pivot can be a 180 or a pivot can be a 3-degree kind of let's just fade. Tell me about, just for you, how did it play out to where you said, okay, my ability to give a damn about places where I should be giving a damn is at 0. That leaves me some shame and guilt because, damn it, I'm better than this, and I don't know what the hell happened. And at some point, you made a change. Something changed. Tell me about that change and where it took you next.
That's an interesting frame of how to think about pivoting, because I think pivoting is often framed as something more than 90, like an obtuse angle, 90 to 180 degrees. And mine was not quite that. It was, well, first of all, emergency medicine is not like riding a bike. There's skills that are kinetic skills, kinesthetic skills that are kind of like riding a bicycle, procedural things, but a lot of it is cognitive. And I talked about this with Rob Orman on a podcast a while back, but skill decay is really interesting to me. And your skills decay much more quickly in cognitive tasks than in physical tasks. And so to that end, you can't really walk away from emergency medicine if you ever intend to come back to it. And there's also quite rigid constraints around being outside of emergency medicine and coming back to it in terms of keeping your credentials at a hospital, meaning your privileges to practice emergency medicine. And they really want to have seen that you've been treating patients continuously with no gaps of more than 6 months. So I have always worked in the emergency department, and I found personally that there was a right balance of shifts that made me not burn out, but also maintain competency. And for me, that's been about 4 to 5 shifts per month. And I've maintained that more or less continuously since I decided to pivot, as you call it. And the training that I did in palliative care was one part of that pivot, but I've done a lot of other things as well.
So your maneuver into something else was continuing to be an ER doc, probably fewer hours, and moving into palliative care, which means you're going back to school, right? This is something you've got to learn how to translate all the skills you've got as an ER doctor, but how to apply them specifically to palliative care.
Right. It is a whole separate specialty. There's another board exam, and I
So
moved
this
for the
isn't a little decision. And so I want to know, if you can, what kind of process, how were you processing this moment of, do I go do this next? How did you kind of weigh out, do I do this or not? Do I get out of medicine completely, or do I double down? Just how did you kind of mentally prepare yourself to give yourself confidence that, no, this is where I want to go?
Well, good question. And I won't say there was one moment of epiphany. I think it was talking to people who were emergency physicians who had made this transition and hearing their experience, getting counsel from people that I spoke to who worked in those fields. Maybe they weren't in emergency medicine in the hospitals that I worked, and better understanding like what it was, what it wasn't. And I had just a sense that I still wanted to be in medicine. And I looked at the sunk cost bias is strong if you spent your entire life trying to be something, and then you're having to weigh the, do I continue being a doctor or not? And it was an easier cognitive exercise for me to imagine, okay, I'll be a doctor, but a different kind of doctor. And going back to this idea of saving lives, it was morally difficult because of the default of people come in, no matter how old, sick, frail they are. What our default is that we do things to them to try to resuscitate them. And that can include a number of different procedures, but in the most extreme circumstances, when someone has had a cardiac arrest and their heart is not beating, is CPR, which is a very violent thing to do to someone. And in short order or in combination of CPR, we're often intubating someone, so putting a fairly large tube through their vocal cords into their trachea to put them on a ventilator, mechanically ventilate them or breathe for them. These are like extremely painful and invasive things. We put catheters in people's bladders, we put large IVs in arms or necks, and it's incredibly dehumanizing. And I've not had it done to myself, but I imagine very painful. So I recognize that patients were in the emergency department coming in who were almost certainly going to die very soon, that the things I was going to do weren't going to delay the death by much, if anything, and were very painful and things I wouldn't want to do to somebody I didn't even like, and the ensuring of comfort towards the end of life is imminently achievable. We have amazing understanding of a variety of medications and non-pharmacotherapy, non-medication ways of alleviating suffering as people are going through the dying process. So that is a goal that is achievable and worthwhile and meaningful, especially since everyone's going to have this experience. And it's not only meaningful for the patient, but it's meaningful for the family who is distraught, even when they know that their family member is dying, that they have this ability to assuage their suffering and have medical people around just to sort of talk them through the process. Because as our bodies die, there are a lot of changes and people stop looking like themselves. And it's incredibly distressing to family. So that process of reassurance and comforting and understanding that we're not trying to change the course of anything. All we're trying to do is ensure that this process that's happening anyway causes at least as little suffering in both the patient and those that love that person. So that to me not only is achievable, but it was also more meaningful because it was something that I could see the results almost in every case that I was making a difference.
When you decided to move into palliative care, where was your dad at on his journey?
He was, it's pretty much a foregone conclusion. If you have Parkinson's long enough, you will develop dementia. It's different than Alzheimer's dementia in the way that it manifests, but it is cognitive impairment, so such that at this point he very forgetful. I mean, he most of the time recognized me. He was bedbound. He had moved into a nursing home, and he shortly actually after I finished my fellowship, he was enrolled in hospice. So he was on hospice care for about 2 years, just at nurse visiting his nursing home a couple times per week. But I was more or less his hospice doctor because for these people that are in hospice care for 2 to 3 years, there's not a lot of changes going on day to day, and they tend to not get the most attentive care because the physician's never seeing them. They're being recertified every 6 months or 3 months, depending on the case, but they're not being seen often by the nurses. So I would see him more often than the physician or nurse practitioner. So I developed a relationship with this hospice agency and the nurse, and I was making suggestions. They're basically taking my suggestions. So it was a blessing and a curse in a way. I don't want to say curse, that may be too strong of a word, but it was odd experience to essentially function almost as my father's hospice physician in terms of the reason. One of the ways I explain the benefits of hospice to patients is that it allows you to be a wife, a mother, a daughter, whatever the case may be, in terms of your relationship to the patient, and not like primarily a caregiver, and let hospice be the ones who are worrying about the medical aspects. You'll still have to help them with like bathing and stuff like that. Hospice doesn't do that, but it'll give you the chance to focus on your relationship with that person and not on their medical care. And unfortunately, that was not like, I didn't have that opportunity with my dad because everyone was turning to me. And I was happy to actually do that for my father, but I do kind of, it was a little bit sad for me that I had to have my doctor hat on as much as I did.
So you were providing hospice care for your dad around the same time you're, I don't know if I'm using it, is it graduating from from this fellowship in
Mhm,
palliative care?
mhm. Yeah, I mean, I wasn't providing care, but I was the one who was basically communicating.
Yeah,
There's no
you were the
nurses.
translator. I mean, you were
Yeah,
there. You were,
and so I would make requests, and the hospice doctor who was overseeing his care would sign off on them almost universally, unless they were. I mean, I didn't make any ridiculous requests for anything that it didn't seem like within the normal bounds of hospice care, but he got much more rapid attention.
hey, everybody. Thank you for listening to Normal 40, the podcast. If you're here, it's probably not an algorithm or an accident. If you're here, it's probably you. And if you're here, I want to invite you to try something else. 2 years ago, I launched a community called The Insider. And when I created it, I thought it was going to be a coaching community where I could come in and teach. But what it's become over the last few months is something radically different. It's a place where we hang out, where we help one another, where we support one another, where people come in really skeptical that there's really a group of people like us doing things like this, and really skeptical if there's anything out there that can be helpful to them. And what they find after only a few calls is that we're really here, we really show up, there really are people in your corner, and that if you lean into it, it can change your life. I'm inviting you to be an insider. It might be the best decision of your lifetime. Go to normal40.com and you'll find the insider, and I hope to see all of you on the inside. Tell me what a day as a palliative care physician, tell me what a good day looks like.
Interesting question. I think the days that look the best are where our time is well spent in terms of how we can provide value. And the ways that we provide value are quite different. I work predominantly doing inpatient palliative care. That means often consults for patients who are hospitalized for things like cancer, heart failure, severe strokes, all sorts of conditions that are serious. And we get sometimes consulted very early and sometimes very late. I often say that the most rewarding consults are when we stop the insanity. And so the insanity can be lots of different things, but it's medical care that is occasionally appropriate and often inappropriate, and depending on the circumstances. So if someone's younger, healthier, has less serious disease, then this treatment makes sense, but for somebody who's in their late 80s has dementia and they're on dialysis and they're thinking about getting treatment for cancer, it's like talking to the family, helping them to understand, I don't think this is going to add time to their life. It certainly is not going to add quality to their life. What's important to them is if it's staying at home, well, this is going to contravene that because they have to leave their home to get chemotherapy and they're going to feel terrible. So showing up at the right moment and helping them at this pivotal decision point so that they make the most out of the limited time that they have left. One of the things that is the most painful to watch is people that are caught up in this. It's almost like a snowball effect of this. A little bit of medical care begets more medical care, begets a hospitalization, begets more procedures. And then this person who had said 6 months ago that they wanted to die at home with their family around them is in the ICU on a ventilator. And I try, if I can see that happening and do something to stop the insanity, as I call it, then I feel really good. That's like a good day in palliative care.
A palliative care physician, who are you really caring for? I mean, I'm obviously the patient, and I'm not suggesting that that isn't the case. But how much of a good day, if we think of a good day and we take all the fancy clinic words off of it, this is a human question, not a doctor question. On a good day, how much of the good you put into the world is for the patient versus how much of it is for the patient's family?
Yeah, no, you're absolutely right that in many cases, the majority of what we're doing is supporting the family. And especially because at the very end of life, almost everyone is unconscious. Some people have these rare moments of lucidity at the last days or hours of life, but most people sort of drift off into a comatose state before they die. And the family's the ones who are around. And like I had said earlier, explaining the process, explaining that it's normal, affirming that they're, being attentive to their loved one is praiseworthy. Palliative care almost, it should be, I mean, the way it's designed is to be multidisciplinary. So there's usually social workers. I mean, hospice has a team that's assigned to you, which includes necessarily, if you're going to get funding through Medicare, it has to have a chaplain, a social worker, and then some volunteer program. And my dad's hospice used to have pet therapy, and pets would come by. People would come and play music by his bedside. These kind of things that are definitely outside of what people normally think about in terms of medical care are actually central to the care for people at the end of life. And that's because end of life care is not about medicine. It's about taking the person away from being a patient and making them back into a human being for the last hours and days of their lives. So the more that we can get tubes and lines away out of people, get oxygen off of people's faces, I think it adds comfort, but it also, for the family, makes the person not look like they are a patient, but makes them look like themselves, albeit, one who's transitioning.
When someone on a patient enters palliative care, how lucid are they? Are you able to have conversations with them?
It's quite variable. So the ideal moment for palliative care to be initiated is at the moment of a serious or terminal diagnosis. So someone gets diagnosed often with cancer, and unfortunately, a lot of cancer, because this initial symptoms are so unapparent, they will present late stage, and the cancer is stage 4 metastasized, and by definition, almost always incurable in those situations. So at that point, that's the best time to meet them so we can introduce ourselves to them as who we are. I like to say, if you have multiple children, this is a very salient metaphor, is that it's hard to watch multiple children simultaneously. So your cancer is one child in this metaphor, and your symptoms of both cancer and cancer treatment are another one. So you want your oncologist to be focusing on the disease, but that is why we come in, because we focus on you, how you're feeling, supporting you through the symptoms of the disease and the symptoms of treatment. So oftentimes patients with serious diagnoses are not introduced to palliative care until they're at the very end stages, and often those patients are not participating in the conversation, which is why it is so important. If I could leave the listeners with like one message, is it's not important as much to talk about your wishes for the end of your life with doctors, although that's helpful. It's more useful to do something called an advance directive and make your wishes known, and then have it clear in that advance directive. If I'm not able to make my decisions, either because I'm confused, unconscious, comatose, whatever, this is the person who should make decisions for me, but I'm not going to put the stress on this person of guessing. I'm going to spell out what I want and what I don't want so that this person doesn't feel like they're having to make a decision whether or not I live or die. They're just expressing my wishes. And I can't tell you how painful the alternative is when I see it happen over and over again, is a wife or a husband who's looking at their unconscious spouse who they've been married to 50, 60 years sometimes, and feeling like they're trying to guess whether or not they would want to continue to be on a ventilator or not.
What changes in a person when the mystery around when they're going to die changes? And while you certainly won't know the time of day or even the day, at some point it becomes very apparent to a physician, and then to the patient, and then to the family, that the end is near. What changes in the patient when that revelation is laid in front of them and they know it's true?
It's very variable. It's quite interesting to see how much variety there is in people accepting that or not. Since death is a foregone conclusion for everyone who is born into this world, it is really our life's work to develop comfort with the fact that it's going to come for us at some point. People variably approach that reality through faith, through meditation and mindfulness practices, but there are a surprising number of people who are 80 or 90 years old and are still lucid and sort of have done little to no work around preparing themselves for their own death. And that typically doesn't go well.
What do you mean they haven't prepared themselves for their own death? I
They
mean,
have
just what?
not,
Go ahead.
no, yeah. So they haven't
You mean
psychologic,
mentally? Do you mean
mentally, yeah.
legally? Do you mean financially?
Well,
Just, I mean,
they often go hand in hand, because doing things like trust and will, advance directive, forces people to think about it. So I want to talk about the denial of death, because it's kind of the perfect segue to this concept. But Ernest Becker wrote this seminal work in the mid 70s, I want to say. He was a psychologist, and the book's called The Denial of Death. And he outlines the logistics and sort of nuts and bolts of why this happens. But basically, we are, to the best of our knowledge, the only species that is acutely aware, at least on some level, that we are going to die. And there is a lot of, if we are thinking about the fact that we're going to die every day, all day, that would be very distracting to having a productive life, to going out reproducing. So his argument is that through the process of evolution, people that were fixated on their own death probably weren't going out and foraging and reproducing. So that trait was necessarily reduced from the gene pool through the process of natural selection. And so those of us that are around today have been selected to be people that aren't inclined to consider our own death. That is to the benefit of us having a productive early and midlife, and to our detriment if we don't recognize that and take active steps. And some people are afraid of the dying process. Some people are afraid of leaving people behind. Some people are afraid that they're not going to have a legacy. They're not going to be remembered. There's a lot of different things that people can fear about the dying process or death itself. And until I understand what among those, or a combination of those, is the most distressing, it's really hard to address. Have you personally ever done things to do preparation psychologically for your own death, or what have you done if you have?
I probably am in the mainstream of where most people are. Smart enough to know that it's going to happen, stubborn enough to think that it'll happen to somebody else before me, but astute enough to have had the conversations with my wife and kids and my parents, whom are still alive, about what my wishes are if something should happen. So I think I'm probably where most people are.
I'd say you're
Uh,
ahead of the curve because you've done the preparation, at least in terms of the documents and conversations. The mental work is hard, and that's why I say it's a lifelong process, but we have our whole life to prepare for it. So if we're lucky, we get a lot of time and we have the opportunities, but that certainly is quite unpredictable. It comes for a lot of people sooner than they imagine. I hope that's not the case for me, and I hope that I'm ready. But it's really kind of interesting. There's a woman named Susan Kubler-Ross who wrote a book, The Five Stages of Grief. If you've heard of her, it's through that work, although she did a lot of other work in her career. And famously, she actually had a very distressing death. And that was because she was made aware of the fact she was dying. She was still lucid and she was terrified. And you'd think, oh, this woman worked around grief, death, and dying her whole life. If anyone was going to be prepared for the experience of dying, it would have been her. And I think we talked about this in our first conversation, but there's been a movement that was very exciting in terms of patients when they are exposed to the reality of their impending death, and they have what is called in medicine and mental health is existential angst that is crippling. And there's not a lot of treatments you can do for that. You can give treatments for pain, for breathlessness, for nausea and vomiting. But if somebody is aware they're dying, terrified, we don't really have a medicine we can prescribe. And the only option we have for when it's really severe is something called palliative sedation, which is essentially sedating someone to the point where they're not screaming and crying in terror. And often that means a hastened death. It's not physician assisted suicide, it's simply striving for sedation. And then, as a secondary consequence, these patients often die sooner than they would have otherwise.
what's the coolest part about the work you get to do now?
I think the most encouraging part is that I get to have relationships with patients and I get to know them as people. One of my favorite things to do is I come in and I ask them something that is totally not related to the reason they're in the hospital. I'll look at their chart and see if there's some mention of something like, they're a fan of some football team. I had a guy who was is because the Super Bowl was just about to happen. He's a Seahawks fan. I asked him to tell me about his love for the Seahawks and what he thought was going to happen in the game. And then we got to talking about how he ran a restaurant. All of a sudden, I know so much about this person that I'm sure that doctors who have known him for years don't know at all. And because I don't really have a goal other than understanding the person so I can understand how that person's goals line up with what's happening with them medically, it's really disarming to patients to have a doctor come in and have, maybe a 15 or 20-minute conversation with them and not really ask them much in the way of medical questions at all. And because the nature of it is relational and understanding holistically who people are, we aren't expected to see people as quickly. So this is not to disparage other physicians and people in healthcare for not having these conversations, because we often don't have time. And in the emergency department, I'm not asking these kind of questions. But I do think it's incredibly rewarding because it gives the person extra dimensions and they sort of are a full actual person rather than a set of symptoms or vital signs or labs and things like that.
Hey everyone, thank you once again for listening to Normal 40, the podcast. Look, there's a reason why this podcast is going to get downloaded thousands of times. And there's a reason why thousands of people show up to what I write and what we share. And there's a reason why hundreds of you join me on The Insider. The Insider is a community that I thought was going to be a place for me to show up and teach and coach. But what it's become is a fan base for people who are ready to get started. It's a place to connect to the people you're going to need for the best decade of your life. And it's the most affordable community, most valued community that I can offer. And I show up in there at least twice a month. And we do live events and have special guests. And I even record podcasts in there from time to time. So look, go to normal40.com, join the Insider, check it out for yourself, and do yourself a favor. Let's be up to something. All right, I'm going to get back to the podcast. All right. So let's wrap like this. Let's assume you've had some time. It wasn't fast. It wasn't immediate. and they did things right. What does that look like for the patient, for the family, and for you?
Excellent final question. So there's a behavioral economist, won a Nobel Prize, named Richard Thaler. He wrote a book called Nudge, and he studies choice architecture. And he famously said in the book, the devil is in the default. And that's so brilliant because what will happen to us if we do nothing is the default. And he outlines how people who have a default to automatic savings of 5%, say for their 401k, are much more likely to have a larger nest egg at retirement than people who have plans that default to 0%. Similarly, the default in medicine, if you do nothing to prepare for the end of your life, is some acute event will happen and someone around you will call 911. You will be rushed to the hospital. If the paramedics find you in cardiac arrest, they will be doing CPR in the back of the ambulance. They'll put a breathing tube in you. You're going to be brought to the hospital. You're going to be kept on a ventilator, sedated, have a catheter in your bladder, have multiple IVs and multiple monitoring devices on. And that is going to be continued until your body no longer responds to resuscitation attempts. So, knowing that's the default, the question is, how closely does that resemble how you want your death to look? For most people, they say they want to die at home, surrounded by loved ones. You have to do a lot of intentional planning and work before your death to have that default avoided, because that is the momentum and default setting of how medical care for people who have serious illness unfolds. So if that's not how you want your death to look, then the first piece is to start with an advance directive. If you're, say, in your 40s, like we are, and you're pretty healthy, then it probably doesn't need to say like, don't do anything to me. I would say that that'd be a little unusual, but it could. But it's just really clear that you outline, if I have this condition, this is how I would want to be treated. And when you get information, a diagnosis, one of your D's, and that diagnosis portends a grim prognosis, I'm not saying don't hope for the best case scenario, but if 50% of the people with that diagnosis are dead in 2 years, and your hope is that you're going to get cured, that's not unreasonable, but it's not practical. So, like the adage goes, hope for the best, but plan for the worst. So to that end, choosing a DNR, do not resuscitate, once you have a non-heart related sort of terminal diagnosis makes sense. And then as you progress, there are varying degrees of intensity of care towards what we call restorative care versus comfort focused care. And as restorative care has increasingly less hope of helping you, and only you're experiencing side effects and burden and time in the hospital, then that's the point where comfort care makes sense. But it's not a decision that happens at one point. It's a ongoing conversation with redefined goals every time there's a change in your diagnosis, your health status. And this should be done in collaboration with the doctors that are treating that disease. And if they're not comfortable with it, and even if they are, I would request a palliative care consult if you or your loved one is facing a serious illness, just because I can't tell you how often it is that we're the first people to have an honest conversation about death with patients. And these are patients that may have had things like pancreatic cancer for years and be in their 80s. And there is a tremendous amount of appreciation, although most patients don't want to talk about it. When they understand that things are not going well and they're frustrated as all hell because they're just in and out of the hospital and nothing's getting better, they're begging, although they don't know how to ask for it, but they're begging in nonverbal ways for someone to just shoot straight with them and let them know where they're at, what their options are, and what makes the most sense. And to that end, palliative care that's what we're there for, and we're the most reliable service, and actually the best. If you look at which groups of physicians can prognosticate, we say the timing of death, we're the ones who have the best ability to make that prediction. We don't lack hope for our patients, but we also have seen patients go through this process over and over, and our pattern recognition around end of life care is the best for that reason.
Yeah, I mean it's a standard bell curve where where on one side of that curve, optimism, hope, push, and cure is what you should be pushing for. But then the reality is, in every single death, there's the downside of that curve. Every single death that isn't instantaneous, like a car accident or something, there's the backside of that curve. I mean, in everything, and having a real conversation on the backside of that curve about what the options are really. If nobody's done that until you, then I can see where that's a relief for people to kind of exhale and know that this is what's next, and this is what finishing well looks like. So I think that's fascinating. You said something that is so simple and so profound and so true. Everything that begins ends. And life is certainly no different, no different than that. And to take a step back and for all of us to think about our mortality and our readiness for it and how horrible it is on one hand, because we don't want to think about it and because it does mean that something is coming to an end. I mean, that is what death is. Something that we know, that all we know, something that we know is it's coming to an end. And preparing for it and talking about it and reasoning through it and getting yourself into this place where we're not looking forward to it, but we're ready for it. We're mentally, spiritually, if that's what you need to be, physically ready for to pass on. I think there could be no better gift to the people behind you than to be prepared to lead them. And it's more than dollars and cents and what's in your bank account. It's with your approach to life. It's with your approach to what you did and didn't do, with your readiness to have the conversations, with all of these really hard things to navigate. And I know you help people do that, and I appreciate that people like you exist to help us have that awkward conversation. That awkward conversation that so many of us are looking for, don't know how to have, don't know how to initiate, don't know how to start, don't know where to start, don't know what it'd look like if we did start it. Thank you for pushing people into having that awkward conversation.
Well, thank you for giving me the platform to discuss it. This topic is relevant to literally everyone, and it feels rewarding to be able to share a message that I know is universally applicable.
All right, man. Well, thanks for being here. Thanks for being on the pod. And I'm going to see you a few clicks up the road.
That sounds great. And if I could just share, if you are interested in my own podcast and blog, thefocusedexam.com, all one word, is where all things that I am thinking about and writing about and talking about are. And if you're interested in talking with me for coaching, that's where you'll find me.
Awesome, man. I'll put all that stuff in the show notes too. And I'll make it very plain and clear on where to find you.
Appreciate it, Lon.
All right, boss man. See you on the next page.
Talk to you soon.